Welcome back. Kirat Singh here, Chief Resident at Vanderbilt. Today I'm going to talk about proximal humerus fractures. Special thanks to the entire orthopedic trauma division, and a special thanks to Dr. Lee from the hand division, who's been very instrumental in our teaching here at Vanderbilt and has had contribution with images to this talk. I'm going to start with some general thoughts. In folks over 65, proximal humerus fractures are the second most common fracture in the upper extremity, second to the distal radius, and they are the third most common fracture overall. Increasing in incidence as the population ages and as lifespan increases as well. 85% of these are non-operative, so if you're blindly guessing if you need to treat these, chances are they're going to be non-operative. The ultimate goal after a fracture like this is to get the patients moving, and in order to move the shoulder, you need an intact rotator cuff, and that cuff attaches to bone, and so the bone has to heal to the remainder of the humerus in order for the cuff to work. So if anywhere along this thought process that is not happening, i.e. the cuff is out or the cuff has pieces of bone attached to it that are no longer healed to the remainder of the humerus, then we have failed and we need to do something. We're going to start with some general terms in anatomy. Cuff tears by themselves are uncommon in a proximal humerus fracture, but functionally the cuff is torn in some of these proximal humerus fractures because for example, your supraspinatus, infraspinatus, and your teres minor, which are attached to the greater tuberosity, and the greater tuberosity is fractured off, then functionally that's a cuff that's not working. But in addition to the fracture, because the energy goes directly through bone most of the time, the cuff itself is usually okay. And the humeral head is usually like an eggshell. And so you get a lot of metaphyseal impaction in older folks. The deforming forces in a fracture like this are basically what's attached to the different tuberosities. The lesser tuberosity has the subscap, which pulls that fragment medially, and the remainder of the cuff pulls the greater tuberosity posteriorly and superiorly. Anatomically, French researchers have determined that there's about 20 degrees of retroversion of the humeral head in relation to the transepicondylar axis, and the neck shaft angle is somewhere around 130 to 140. Always do a neurovascular exam after these folks present to you, somewhere around the order of 40 to 45% neuropraxia, usually most commonly of the axillary nerve. There's no real good classification system. There's poor intra and inter-observer reliability when it comes to the near fracture classification. Nonetheless, a near part is a piece of bone in this area, and those four pieces are either the greater tuberosity, the lesser tuberosity, the humeral shaft, or the articular piece, which is the head piece. Those are the four pieces, and if any of those pieces is displaced from the rest by a centimeter or is angulated greater than 45 degrees, that's considered a near part. Also, considering some of the vascular anatomy in the area, there was some debate early on about which vessel supplied the humeral head, whether it was anterior or posterior circumflex vessel. Initially, it was thought that it was the anterior circumflex vessel, which gave off the anterolateral ascending branch, which then terminated as the arcuate branch. More recently, they've done some anatomical studies, and the posterior circumflex vessel is anatomically larger and is thought to be a more significant contributor to the humeral head perfusion. In reality, there are probably a bunch of intraosseous anastomoses which contribute to the overall vascularity of the humeral head. So posterior circumflex is a more significant contributor than previously thought. Somewhere along the line, you may hear about Hurdle's criteria, and this is helpful for when you look at the fracture films initially, and you can look at how much metaphyseal bone is still attached to the humeral head piece. And if it's greater than 8 millimeters, there's a good chance that the vascularity to the humeral head is still preserved. In addition, if you look at the medial hinge, and I'll explain what a medial hinge is in the next slide. But if you look at the medial hinge and it's less than 2 millimeters, that's a good sign for vascular perfusion to the humeral head. If it's greater than 2 millimeters, there's a chance that the blood supply to the humeral head may be compromised. So what I mean by medial hinge is if you look at that illustration, and you can see the hinge on the medial side as labeled there. That's a non-displaced fracture, but if that is gapped, then the idea is that the periosteum and everything is kind of torn on that side, and the predominant vasculature is also disrupted. When you have a patient with one of these, it's important to have imaging, and 3 views is always appropriate for the shoulder, the AP. And remember, the AP of the shoulder, the true AP, is also called a Grashy view, and it's taken at a 30-degree oblique angle in the axial plane, and that's because the anterior portion of the glenoid is actually more medial than the posterior portion. So you kind of shoot the beam like this. That's the AP. The axillary is can be shot either from top down or bottom up, and if the person can't really lift their shoulder up and give you an axillary view, you can shoot a Velpew view, and I've already talked about that in one of my shoulder anatomy talks in one of the previous podcasts. The scapular Y, for the purposes of the shoulder, is the lateral view. These are important views to obtain because sometimes you can have a fracture dislocation, which is not only a worse prognostic indicator, but it also has implications for how you approach the fracture. CT scan is sometimes useful in judging impaction and bone loss. Some folks will also get 3D reconstructions. That's variable based on institution. MRI really has no indication in the fracture setting. A word on bone density. It's important to know what kind of bone you're dealing with prior to boarding a case and deciding whether you're going to do a hemiarthroplasty or trying to percutaneously pin the bone. It sometimes is a bonus if the person has already had a bone density scan, but that's not always the case. Some papers have shown that you can get a sense of how good the bone is, how dense it is, based on looking at the diaphysis of the humerus. So what you do is you pick a point where the cortices, the medial and lateral cortices of the humerus, become parallel. You look at the cortical thickness there on one side, so you pick the lateral side or the medial side. Then you go 2 centimeters distal and you check the cortical thickness there, and then you average that thickness. And if it's greater than 4 millimeters, there's a good chance that bone is going to hold good fixation. It's important I mention this slide on bone density only because it'll help you in your preoperative planning. For more discussion on preoperative planning, see Dr. Boyce's separate podcast on preoperative planning. There are a variety of ways in which you can treat a proximal humerus fracture. Most of them will be treated non-operatively. The idea is that if the fracture fragments are not wildly displaced, i.e. there are really no near parts, or maybe there's just one, the idea is that in about 2 weeks, the bone fragments are going to get sticky, come together, and the cuff will still be working, and in about 2 weeks, they'll be able to range their shoulder and progress to physical therapy. If you feel like they are not going to be able to move their shoulder because those pieces are too wildly displaced, then you may want to consider getting out of the non-operative idea and moving to something operative, and that something can be transosseous suture fixation. And transosseous suture fixation is where you use something like a heavy suture. You can use something like number 5 Ethibond or number 2 Ethibond. Sometimes even something like Merceline tape, which looks like a ribbon, and do a tension band technique. Also, you could do closed reduction percutaneous pinning. This is sort of it carries risks of injuring the axillary nerve, the musculocutaneous nerve, especially if you're coming anteriorly, and injuring the biceps tendon. Some attendings I've seen use a 15-minute rule, and that is if you can get it close reduced and restore the medial calcar in that amount of time, then they'll put a 4-5 or a 625 K wire, immobilize that in place for about 5 to 6 weeks, and then let them start ranging it thereafter. Problems associated with closed reduction percutaneous pinning are that there's a risk of stiffness as well as pin loosening, migration, and infection. The more commonly seen thing is open reduction internal fixation. We'll talk more about that in the slides to come. Most folks are using locked plating, and that's because of the fractures that we're seeing in the elderly folks with osteoporotic bone. And you have to, again, restore that medial buttress, that medial calcar, and that's an important goal of the surgery. When you put that plate down, it should be, the top of the plate should be 8 millimeters distal from the superior aspect of the greater tuberosity on the AP X-ray. Otherwise, if you send it too high, if the plate's sitting too high, as you go into abduction, you're going to impinge. Other treatment options continued are intramedullary nailing. So there is some concern that you're not going to be able to adequately obtain fixation in at least a 3-part fracture with something like an IM nail. The implants are still lagging. This is a technology used more commonly in Europe. Another drawback of an IM nail is you have to violate the cuff upon insertion. Again, if you do see one of these that already has an IM nail in place and it comes to your clinic for evaluation of a non-union, then you proceed with something like removal of hardware and plate fixation with or without bone grafting, depending on the type of non-union you're dealing with. Next, getting out of sort of fixation is more head replacing technology, and that is a hemiarthroplasty. If you're going to do a hemiarthroplasty, you have to make sure that you can get the tuberosities to heal. Early on, as an intern, I never even thought, I wasn't sure exactly how a hemiarthroplasty sat in the shoulder. I thought you took out everything and maybe left the diaphysis and put this humeral head in, and everything just kind of attached somewhere there. That's not true. You need the greater and lesser tuberosity intact if you want to do a hemiarthroplasty. And if those tuberosities are dusted and you can't anatomically get them to heal, hemiarthroplasty is not a reasonable choice because the cuff is not going to work. It's not going to have anything to attach to. Folks will continue to have pain. If you can't get the tuberosities to heal, your next option is a reverse total shoulder. And I'll touch on this with 1 or 2 slides, but it won't be the focus of this. This is the last stop on the track because there's really no bailout after something like this. So ultimately, after you see one of these proximal humerus fractures come through the ER or in your clinic, I kind of break it down into 4 big questions. The first question is, do we operate or not? And this decision is largely based on the patient's age, comorbidity, the number of parts. Obviously, a 4-part humerus fracture in a 22-year-old is going to be treated operatively. But a 80-year-old with a 2-part where the diaphysis is maybe 50% translated off the humeral head, maybe something that is going to be treated non-operatively. And what's the likelihood that you're going to be able to get them back into rehab and ranging the shoulder in 2 or 3 weeks? If you look at the x-ray and your gut tells you that that's not going to happen, then you need to consider operative fixation to ultimately help them with mobility. After that question, once you've decided operative or non-operative, if you are going to operate, are you going to do something head preserving or head replacing? And if you're going to do something head preserving, then what are you going to do? Are you going to do closed reduction percutaneous pinning? Are you going to plate it, nail it? Or are you going to do something with suture fixation? And the caveat here is, although in academic discussion you see situations where there's transosseous suture fixation and closed reduction percutaneous pinning, by and large, most of these are treated with plate fixation. And the final question is, if you're replacing the head, are you going to do something like a hemi or a reverse? And that decision is predicated largely on the integrity of the tuberosities. There are several ways in which you can set up the OR and your approach. The positioning is usually supine or a beach chair. We do it both ways here at Vanderbilt. You can use the Steris bed and position the patient's head at the foot of the bed and pull the patient to the edge of the bed and put a big piece of plexiglass board underneath the padding of the table so that you can have additional space to work with, and the plexiglass is radiolucent, so you can shoot x-ray through this. The advantage of the beach chair is that the shoulder is actually sitting higher than the heart, and so there's less blood loss. The approaches are either going to be your deltopectoral or your deltoid splitting. For your deltoid splitting, this is sort of a helpful approach for if you have just an isolated greater tuberosity piece that's popped off. And you can split the deltoid directly laterally. Be careful about the axillary nerve, which runs about 5 centimeters distal from the acromion. If you do the deltopectoral approach, it's an approach that starts from your coracoid and works, is going to be in line with the lateral epicondyle of your humerus. Obviously, you don't make the incision all the way down, but those are your two proximal and distal palpable landmarks. I do want to mention something on bone loss as well. Again, at the beginning, I mentioned that some of these fractures are come with a good deal of metaphyseal impaction. In those scenarios, there's a few things you can use. Some of them include fibular strut, femoral head, which you can cut into a piece of like a trapezoid and put that in between the eggshell of a metaphyseal head, eggshell of the proximal humerus and the diaphysis. These are all structural allograft. If you've obtained a preoperative CT scan in a 70-year-old who has a comminuted proximal humerus fracture that's wildly displaced, you may want to consider some kind of structural allograft. And it's important because in your preoperative planning, this may be something that may not readily be available in and around the OR at the time you need it. Additionally, you can use morselized bone graft. This can be auto or allo to pack in some of that defect. And then there's also synthetics like calcium phosphate, which is Neurion, that you can inject in and around the area of bone loss. Let's talk about positioning in the OR. The patient here is positioned supine on a bed. You raise the head of the bed and you put a bump behind the shoulder. You drape in the entire upper extremity and the shoulder area. Have x-ray positioned at a 90-degree angle to the patient with the base of the C-arm on the operative side. You basically put these drapes that we here call our 10-10 drapes all around the shoulder area as shown in that picture. And after it's been sterilely prepped, you put an up sheet, a down sheet, 2 sticky blue U drapes, and then 2 U drapes on top of those. And then you I-band the edges as well as the axilla, which contains a variety of pathogens. And then you put a stockinette on the hand all the way up to the elbow, put some Coban over it, and then you remove that arm board that you see in that image because as a surgeon, you have to be able to stand right near the shoulder. You can bring a padded Mayo in if you don't have an assistant to help you kind of hold the arm in place. Here is the standard deltopectoral approach. This is from the AO website. Again, coming from the coracoid. And the coracoid is a structure that sort of points inferiorly. And so you almost have to bring your hand inferior to superior to really kind of feel the hook of that sometimes in obese patients. In any case, there's the cephalic vein. The cephalic vein can either be taken medially or laterally. If you take it laterally, you can preserve some of the venous outflow from the deltoid muscle that's feeding right into that cephalic vein. Some folks like to take it medially. In any case, you can see it in a fat stripe, and you can spread down there with Metzenbaum's scissors. After that, you can get your hand underneath and develop a plane underneath the deltoid and get a Hawkins-Chandler retractor deep to the deltoid, go from medial to lateral, and that helps you start visualizing some of the bone. You're already going to run into fracture hematoma there. If there is difficulty in getting a retractor or visualization underneath the deltoid, you can release some of that deltoid insertion along the proximal lateral aspect of the humerus. Then, as you see, the pec major muscle is going to come across the intertubercular groove and attach on its lateral aspect. You can release some of that superiorly and visualize the biceps tendon behind it. Some folks at our institution will then grab the biceps tendon with a O-vicryl and tag it down in place. If there's any concern that a fracture line propagates in through the intertubercular groove, folks will tenodese the biceps so that it's not irritating itself as it slides in and around the fracture site as it's healing and leading to biceps tendonitis. Once you have the exposure, again, you have a Chandler retractor behind the deltoid. Some folks will like to use a Covell retractor. I'll let you guys Google that. It's basically a sort of a Wheatlander retractor, but with blunt edges that'll help you hold the deltoid out laterally and the pec muscle medially. In any case, once you come upon the fracture, it's a basic fracture reduction at that point, in the sense of you clean the fracture site with curettes, rongeurs, and bulb irrigation. You don't necessarily have to have fresh irrigation every time. You can just take the bulb with an explosive maneuver, get the hematoma flushed out, and then suck that water right back into the bulb, and again, back and forth. That helps save some vital intraoperative time. After you've cleaned out the fracture site, it's important to start tagging the greater and lesser tuberosities and put the needle of your tag stitch, whether number 5 Ethibond or something heavy, put the needle, put the suture into the cuff itself, not into the bone. If you put it into the bone is not really going to hold much, and you're going to end up comminuting the fracture even more. Leave the needles on the suture after you're done passing it, because depending on the type of plate you're using, you may want to end up passing that suture through the plate afterwards. Reduce the fracture. Usually the problem is the fracture is apex anterior, so this involves putting a hand behind the elbow and raising the elbow skyward. Additionally, abduction and adduction may be needed, rotation as you see fit. Once the fracture is reduced, provisional fixation with any kind of 6'2" K-wires or larger K-wires, whatever seems to work. Position the plate. As I've already mentioned, it has to be at least 8 millimeters distal from the tip of the greater tuberosity to avoid impingement. Start with the oblique hole. At least here we use some of the Synthes plates. And hopefully when you've initially pinned the fracture, you've pinned outside of the plate. Otherwise, you're going to have to go back and repeat step 1. Place the plate down laterally. Use the oblique hole, the oblong hole along the lateral aspect first so that you can shift the plate up and down. Drill with a 2.5 drill bit so you can put a 3.5 cortical screw in there. That helps you, again, with translating the plate superiorly or inferiorly as you see fit. Once you have that down, there will be a place to put a screw, the Calcar screw. And so what I mean by the Calcar screw is the one that you see shot obliquely, and it's the distalmost screw in the proximal cluster of screws. And you can see how it kind of rests right along the medial calcar, and that's ideally where you want it to sit. Each plate will come with a guide that lets you know which one the Calcar screw is, and you can shoot a K-wire initially to see whether your screw is going to sit nicely along the Calcar or not. So once you've initially placed a screw in the oblong hole, and you've now preliminarily put in a K-wire for your Calcar screw, you can then make fine-tune adjustments to your plate, and then put a guide along the proximal portion of the plate, drill with 2/8 millimeter drill bit for the 3/5 locking screws. Again, check fluoro as needed. The positioning of the fluoro has already been mentioned, so it'll help you with obtaining an AP and an axillary at the same time. Without having to make any major adjustments to the C-arm machine, you can just rotate the arm. And then finally, it's important to make sure that you don't put any screws in the actual glenohumeral joint, so taking the shoulder through a range of motion, sometimes even maybe live fluoroscopy may help. Take the number 5 Ethibond through the plate. Again, that's why I told you to leave the needles in place on the suture. Take it through the plate and suture it down. That helps with the overall fixation, especially when you're struggling and the bone is really starting to feel like powder. Finish the shaft screws. They should just be your sort of normal 2/5, 3/5 screws. Irrigate, obtain final fluoros, and then finally the biceps should be tenotomized and then tenodesed with a heavy suture like number 2 Ethibond. You can close the skin with Vicryl if there's some concern for infection. Monofilament, something like a 2 monocryl is appropriate. Another reason to use monocryl is that it absorbs through hydrolysis, and whereas Vicryl absorbs through something like an inflammatory reaction. And seeing these patients post-operatively, a suture that is absorbed with sort of an inflammatory reaction, sometimes it's a little harder to delineate between an infection that's starting to develop versus just normal suture absorption. So monofilament in a scenario where you're worried about infection, and then nylon or staples in the skin. And then finally, non-weight bearing for about 4 weeks while everything is healing. You leave them in a sling. Again, a word on sling management for the non-operative cases. When I used to see these folks down in the ER, I would cut a hole in the sling so that the gravity can allow the diaphysis to sort of sink down in that hole I've cut in the sling, as opposed to if you don't cut the hole in the sling gets on and puts the entire force down in through the shaft, and then the fracture site is actually just can sometimes be malreduced, and in addition to it being painful, it's just not an anatomic position to be in. In scenarios where you're worried that the bone quality is poor, you may want to consider preoperatively planning for something like a hemiarthroplasty. If you know that the plate you're going to put on is really not going to have much capture, despite it being locking technology, you may want to have some hemiarthroplasty equipment and implants in the room. Again, for hemiarthroplasty, as I've already mentioned, tuberosity reduction is critical. If the greater tuberosity is fixed too distal, it's going to over-tension the cuff. And again, if you don't put the tuberosity distal enough, it's going to be too loose. So again, anatomic reduction of tuberosities is very important in pursuing a hemiarthroplasty. So once you have placed the prosthesis in, it's important to understand whether you're sitting too superior or too inferior. And generally, you want this greater tuberosity to be positioned about 10 millimeters or so distal from the superior aspect of the prosthesis. An anatomical study said, hey, the superior aspect of the implant should sit about 5.6 centimeters from the superior aspect of the pec major insertion. So that's another anatomical marker that you can use. As well, it's important to obtain, again, anatomical reduction between the greater and lesser tuberosities, and you can do that by taking suture from the greater tuberosity and taking it all the way to the lesser, putting horizontal sutures. If you over-tension this, you're going to end up cracking the bone. If you under-tension, that risks gapping and malunion. So again, positioning of the implant and then horizontal sutures between the lesser and the greater tuberosity are important. In addition to the horizontal sutures, you also need vertical sutures, so to be able to hold the tuberosities down to the remainder of the diaphysis, take suture into any bone or any soft tissue that you can see, and in addition to the horizontal suture, send the vertical suture down. Again, I've already mentioned that you can use the pec insertion as a helpful anatomical marker as well. Cementing, you have advocates for and against. If you're worried about poor bone quality in general, which most of these folks usually have, cementing may not be a bad idea. And then finally, you want to put this implant in about 30 degrees of retroversion, and you can use the bicipital groove as a indicator of where anterior is and where 30 degrees retroverted is. So send the fin of the implant 30 degrees off in relation to the posterior margin of the bicipital groove, and you should be okay there. As well, folks can start doing some pendulum exercises post-operatively, and you can start getting them to do therapy, active range of motion once there's signs of healing on radiographs, usually after their 3 or 4 week post-operative visit. If you don't reduce the tuberosities appropriately, you're going to end up with tuberosity malunion, and that's usually a cause for pain and failure. Again, the goal is reliable pain relief, and you can obtain that usually with a hemiarthroplasty, but there is some loss of motion, some loss of range of motion with that. Finally, a word on reverse total shoulders. This is the end of the track again. So this may be a good idea in an elderly person who really can't do physical therapy, or you can't get the tuberosities to heal. So this is that scenario. I'm not going to talk about the technical aspects of the reverse in this talk. Again, malpositioning of these components, if you end up placing the components in a non-ideal situation, what's going to end up happening is that humeral cup is going to then smash into the lateral aspect of the scapula, and that's going to lead to notching, especially with the adduction motion. Finally, a few other things. It's important to be able to get the tuberosities to heal down. Some folks say, hey, fiber wire is traumatic to the tissue and can cut out, so you can use something like Merceline tape instead. Tuberosity reduction, again, is critical. I can't harp on that enough. You can tenodese the biceps. Again, if the fracture line is in the bicipital groove, not all folks will do that, but it may help with bicipital tendonitis in the postoperative phase. AVN of the humeral head is not as catastrophic as one would always think. It's because not all AVN of the humeral head, even ones that have collapse, are going to be symptomatic. And then the valgus impacted 3 to 4 part proximal humerus fractures actually end up having a much better outcome than your usual 3 to 4 part proximal humerus fractures, and that's largely because the medial hinge and the medial periosteum, blood flow, and all that is still intact. The fracture stems in a hemiarthroplasty are going to be different than your normal hemiarthroplasty stem, and that's why it's important to preoperatively plan and tell these folks what you need in the room. It's because these stems are actually smaller proximally, and that allows for the tuberosities to be able to come together and heal. And they're also grit blasted and have some holes for which you can pass suture through. And it's okay to use a small stem because most of the fit of this hemiarthroplasty is going to be proximal. You don't necessarily need a big long stem that goes down into the diaphysis and obtains fit in the diaphysis. I hope this talk was useful for you. If you have any questions, please send me an email. My email is down there. Otherwise, you can always come to Vanderbilt and have a discussion with us or come visit with us. Thank you.